Good afternoon, everybody. I'm Oscar Rosales, a cardiologist at Memorial Hermann Hospital in the Texas Medical Center. For the last 7 years, I have been the director of the Cardiac Catheterization Laboratory. Although my practice includes most of cardiovascular interventional work, my first love is vascular disease. This afternoon, I would like to share with you some of the features of vascular disease that have significant relevance in the community. These are the objectives of this short program. The first one is to raise the level of awareness about vascular disease, how prevalent and how complex in terms of treatment and prevention it is. Second is early diagnosis of vascular disease, what tools we have there available to us. In addition, I would like to expand on new areas of treatment for wound management and long-term healing, primarily with emphasis on how to restore blood flow to save limbs, which many times translate into saving lives. And clearly, to save a limb requires a multidisciplinary approach rather than just a cardiologist or a podiatrist or a wound care specialist taking care of the patients. First, what is the diagnosis of peripheral arterial disease or peripheral vascular disease or peripheral arterial obstructive disease? All these are synonyms of the same process. The definition is basically the obstruction of large peripheral arteries that excludes the brain and the heart from a condition called atherosclerosis, which is the development of plaques in the blood vessels as a result of long-term inflammation in the vessel wall. Now also the arteries may become obstructed because the heart forms a clot and ejects that clot to the different organs, what is called an embolism. Or at times, just like in the heart, plaques form of cholesterol and other materials can rupture, allowing the formation of a clot locally, which may lead to an acute obstruction of blood flow. The medical term for an acute or chronic lack of blood flow is ischemia. When we see patients with vascular disease, we tend to classify them because the label that we apply to the patient has great connotation in terms of prognosis and long-term treatment modalities. Patients that have no symptoms can be considered grade 0. Patients that are able to walk more than 150 meters without pain upon walking in the calves or in the foot, they are labeled as mild claudication. If you are able to walk less than 150 meters, that's considered class 2 or moderate claudication. Those who can only walk a few yards, yet they do not have pain at rest when they are watching television, for example, they are considered severe claudicants. When the condition worsens and there is significant obstruction to the blood flow, usually in multiple levels between the groin and the toes, that leads to pain at rest, called resting pain. Ulceration and gangrene are just extreme modalities of peripheral arterial disease in which the patient is at risk of significant tissue loss, including loss of the limb entirely. What symptoms usually bring the patients to the physicians? 20% of the patients with mild disease have no symptoms. Yet, patients with diabetes, long history of cigarette smoking, or advanced renal disease on dialysis usually presents without symptoms, and ulceration and or gangrene is the first manifestation of it. This is quite similar to patients with heart disease that don't know that have heart disease and present to the emergency room with a heart attack as the original presentation. Now, those who have vascular disease symptoms for quite some time come to the physician complaining of limb weakness, cramps in the calves, usually, pale discoloration of the toes, blue toes, the temperature of the foot drops, or there is diminished hair and nail growth in the lower extremities. What are the causes of vascular disease? The underlying mechanism of obstructive disease or plaque formation in the blood vessels of the legs, and the same applies to the heart, is inflammation for the long term, precipitated by risk factors such as cigarette smoking. Cigarette smoking in the setting of arterial disease of the lower extremities is probably the most important modifiable cause, because it enhances the risk of obstructive disease in the lower extremities up to tenfold. Patients with diabetes are also the second in importance for obstructive disease. In the United States, 70% of amputations of the lower extremities is or happens in patients with diabetes mellitus, those that did not lose their legs because of trauma. And the risk of vascular disease, if you happen to have diabetes and only diabetes without smoking or hypertension or high cholesterol, is 2 to 4 times an increased risk. Cigarette smoking is as high as 10 times. Other causes that we always look for: elevated cholesterol, what we call the LDL cholesterol or bad cholesterol. Patients with low good cholesterol, also called HDL cholesterol. Elevated triglycerides, which is a type of fat derived primarily from carbohydrates. Homocysteine is a substance that has been recently recognized as another precursor or developer of vascular disease, particularly very high levels. One of the interesting things about the homocysteine elevated levels is that can be successfully treated with folic acid, which is a vitamin available over the counter. Hispanics and African Americans are at higher risk than white males and females. Obesity, male more than female patients do develop vascular disease, elevated blood pressure, or family history of vascular disease. This slide illustrates the odds ratio or relative risk of developing vascular disease depending on the risk factor. If you happen to be male gender over female, the relative risk is twice in male that of females. As we get older, the risk of developing vascular disease increases. Diabetes, as you see, the risk is 3 to 4 times, and smoking, as I said before, can be as high as 10 times, but usually in most of the publications is between 4 and 5 times. High blood pressure, elevated cholesterol, elevated homocysteine level, Asian, Hispanic, and blacks versus white, the odd ratio is 2. An inflammatory molecule that we can test these days in the blood is called C-reactive protein. When it's elevated, it's usually a marker of inflammation in the vasculature. That also increases the risk of vascular disease. And patients with kidney problems, particularly those with advanced renal disease on dialysis. When the patient comes to the office, the first item is a complete clinical assessment, which includes risk factors such as cigarette smoking, diabetes, high blood pressure, high cholesterol, etc. Location of the symptoms, when do they present and what makes the symptoms better? What is the relationship with walking or sitting? And if the patient has any previous medical or surgical history that could have impacted on the development of vascular disease. For example, patients who have knee replacement many times sustain vascular injury of the blood vessel behind the knee that may lead to severe vascular problems down the road. History of cigarette smoking, sedentary lifestyle, alcohol use, family history of vascular disease are all important. When the physician sees you in the office, in addition to taking an excellent history, a complete history, a complete physical examination should take place of all palpable pulses, that we know where the location is. That includes upper and lower extremities. Why? Because there is a simple test called the ankle brachial index, which we can measure in the office to determine the extent and or the severity of the vascular obstructive disease in the lower extremity. Let me walk you through the slides. One takes the blood pressure in both upper extremities and take the higher number. Then one takes the blood pressure in the lower extremity, let's say the right leg. For the purpose of this illustration, observe that the blood pressure behind the ankle says 40 and the blood pressure on the front of the foot is 80. So we take the higher of the two numbers in the right foot. So the index for the right leg will be 80, which is the higher number of the two, over 160, which is the higher of the two blood pressure in the arms. For the right leg should be 0.5. Now, when we get the report that says 0.5, as you observe, that doesn't tell us much about the fact that the patient has more severe disease in the other blood vessel of that lower extremity. So the segmental index in the part inside the ankle should be 40 over 160, which is only 0.25. So the ankle brachial index many times is reported in an incomplete way, and that's why it's important to include segmental pressures in addition to the total index. This is the clinical course of patients with vascular disease in the lower and or upper extremities. On the left, we have normal subjects. Then, because of risk factors and or other issues, develop arterial disease. As arterial disease progresses and becomes multi-level, the patient develops what we call critical limb ischemia, or CLI. Critical limb ischemia relates to conditions in which the patient has pain at rest or the presence of ulcers and or gangrene in the lower extremities. And once we develop significant gangrene, in a very important percentage of cases, the patients end up losing their leg or losing their lives. These slides illustrate how important is the recognition of advanced vascular disease. I share with my students and fellows all the time that advanced vascular disease is just as bad as the worst cancer. If we have 100 patients with critical limb ischemia today, in 12 months, only 45% of them will have both legs. A third of the patients will end up losing the legs, and 25% of the patients may die during those 12 months. Of notice is the fact that in a significant percentage of cases, as much as 25%, particularly diabetics or patients on dialysis, they have no previous warning signs when they develop gangrene or ulcerations. And this usually happens so quickly, and the progression of the disease is so fast that the patients, unless they receive the most sophisticated and multidisciplinary care, they end up losing the leg or their lives. Some of these patients die because of complications of surgery related to amputation, or because they have coexistent vascular disease in the heart and in the brain. So strokes and or heart disease take their lives. This is an angiogram of one of our patients here at Memorial Hermann that illustrates the critical nature of these blockages at the level of the ankle. These images illustrate blood flow between the calf and the ankle in this patient. Observe that only one blood vessel is seen in there. All other blood vessels have critical blockages. There are normally 3 blood vessels at the level of the ankle. Here you only see one, which is just very, very small in diameter. This is a typical example of multi-vessel obstructive disease, which leads to ulcerations and gangrene. So the goal in cases like this is to restore blood flow in as many vessels as possible. In most situations, we do not need to open every single one of them, but clearly we have to concentrate on the one that will give us the greatest return for the investment. In cases like this, surgery is not an option because there are no places where the bypass can go. In these cases, the only option is to visit with an first-class endovascular interventional cardiologist or vascular surgeon who does this kind of work, or radiologist who knows about this, to use one of many techniques available to us to recanalize or reconstruct these blood vessels without surgery. This slide illustrates the 6 different compartments in which we divide the foot depending on the blood vessel that goes to a given part. For example, the red color illustrates the part of the foot, which is the front of the foot, that receives the blood flow from the anterior tibial artery. On the back of the ankle, where it says posterior tibial artery, that's fed by a totally different artery that runs behind the middle part of your ankle. That goes to the plantar surface of the foot, to the yellow and blue colors. Those two arteries are called the plantar arteries. The other two sites, green and purple, illustrate the two sites where the peroneal artery, which is the third blood vessel from the knee to the toes, provides the blood flow. When the patients come to us with an ulceration or gangrene, it's important to know where the gangrene and or the ulcer is present, because we have to go after the blood vessel that feeds that site. If we go after a different blood vessel, yes, you get better blood flow to the foot, but you don't heal. So the concept of angiosome, which means what is the block of tissue, where is this block of tissue and what vessel goes there, is absolutely important these days on defining the strategy at the time of treatment. The anterior tibial artery is one of the three arteries between the knee and the ankle. There are two others, the posterior tibial and the peroneal. But the anterior tibial and the posterior tibial are the only two that reach the toes. The peroneal ends at the level of the ankle. So if the patient has an ulceration, let's say on the second toe, and is on the dorsum of the foot, on the front of the foot, the vessel that goes there is the anterior tibial. So therefore, one must intervene there and hopefully be successful in the complete recanalization of the vessel. If one happens to target the peroneal artery that ends at the ankle, the patient will not get better. So if any of you in the audience has an ulceration and or gangrene, ask the treating physician if the appropriate artery was intervened. This slide on the left, or the image on the left, illustrates the blood vessels from the hip all the way down to the toes. From the hip to the knee, the main blood vessel is the femoral artery. And there, because of the size, we have very many options, including balloons, stents, rotorotors, cutting chambers, and many others. Between the knee and the ankle, the blood vessels are smaller, similar in size to the blood vessels of the heart. Many of the same strategies are available, but of course in smaller sizes. And at the level of the toes, the technology is clearly much, much smaller in cases where finesse is the key to success. With this slide, I want to share with you that we have very many options, very many tools these days to help patients with advanced vascular disease. Now, a few slides about wound healing and what it takes to make the patients better in the presence of critical limb ischemia or advanced vascular disease. First, I want to reiterate, success means team approach, and that includes your endovascular specialist, your podiatrist, plastic surgeon when it's necessary to do grafting of a skin graft, for example, orthopedic surgeons for amputations of toes or at times limited amputations of the part that has sustained gangrene and we cannot restore normalcy. Most of these patients have diabetes or kidney disease, so the endocrinologists and nephrologists are key. Physical therapy is an essential piece, as well as a wound care center. Just as I shared with you before, patients with ulcerations or gangrene in the lower extremities, this condition is as serious as advanced heart disease or advanced neurovascular disease with a stroke, with impending stroke, or cancer. So there is no place for ego here. This is all teamwork. One of the keys is to identify the problem early on, before wounds, ulcerations, gangrene develop. Now, if the patient presents with gangrene or wounds as the first presentation, good wound care is essential. That means careful assessment, cleaning of the wounds, what is a medical term called debridement. The wounds should be treated with a warm and moist environment. Relieving the pressure of that foot is essential. And there are many creams and topical treatments these days to accelerate wound healing. There are also new and available technologies to us, such as growth factors, bioengineered tissues, biologic dressings, active topicals, substances, particular enzymes that degrade the dead material. Plastic surgery is needed many times, as well as reconstructive surgery. Follow-up. Let's say that we happen to be successful and the patient now has adequate blood flow to the site of the problem. Patients need frequent and careful follow-up, including risk factor modification of diabetes, cigarette smoking, blood pressure control, treatment of elevated cholesterol, in addition to complete vascular examinations. In the office, one can calculate what blood flow or blood pressure is present in the lower extremities by doing the ankle brachial index that I explained before. Many of these patients have coexisting vascular disease, so aneurysms in the abdomen, blockages in the renal arteries, coexisting coronary disease should be explored. Smoking cessation is key, as well as supervised exercise and diet. As I shared with you before, the most important risk factor that can be modified is cigarette smoking cessation. This is a relatively new strategy for patients with wounds that don't heal or have slow healing processes, which is called negative pressure, or also called by the term of wound vac or wound vacuum. It's negative pressure applied to the wound that removes the dead tissue and promotes the growth of healthy tissues. Now, this should be done ideally in conjunction with better vascular flow. Things don't heal unless we have nutrients and oxygen. So the first step is to restore blood flow to the site of the wound. The second is excellent intensive wound care. The third one, if in cases like this where there is significant tissue loss, apply this wound vac or negative pressure. Many patients also benefit from hyperbaric oxygen treatment. But to benefit for high oxygen pressures inside these chambers, one has to have recanalization of the closed blood vessels with continuous delivery of blood flow to the site where the ulceration or gangrene is present. When we have comprehensive foot care programs, the amputation rate is reduced from as little as 45% to as much as 85%. Don't forget about the slide in which we illustrate that at 12 months, in those with ulcerations or gangrene, only 45% of the patients will have two legs, 25% will be dead, and 30% will lose one of the limbs. I would like to reiterate one more time. Find a physician who has love for this problem, who can shepherd you through the process that it will take to achieve wound healing. And as I shared before, implies including wound care specialists, podiatrists, nephrologists, endocrinologists, vascular specialists, interventional cardiologists. It's a multidisciplinary approach. One person alone cannot fix your problem. If you are interested in additional information, you can go to the website of a foundation that I'm blessed to lead, which has been developed through donations of my grateful patients with vascular disease. The name of the foundation is HoustonVascularHealth.org. It's a foundation dedicated to research, innovation of new technologies for the treatment and prevention of vascular disease, and hopefully complete prevention of amputations one day. On behalf of Memorial Hermann, our Heart and Vascular Institute, and the University of Texas Medical School, I have been honored to share with you this webinar. I'm open to any questions. I think everybody can see the question is a person who is 61 years old with a family history of vascular disease. Unfortunately, the type of vascular disease was not stated. There are some processes which happen to be genetic in nature, others that are acquired. But let's assume that this is the most frequent variety of vascular disease, which is arterial obstructive disease of the lower extremities as we get older. It's key, 1, to quit smoking, 2, to lower the cholesterol to normal levels, 3, to increase the good cholesterol as high as possible with diet, exercise, and occasionally with the use of a medication called niacin. 3, if you happen to have diabetes, tight diabetes control is a must. As I share with you, diabetes and smoking are the 2 key factors. Once you get diabetes, a lot of people develop kidney disease. And once you develop kidney disease, now we have diabetes plus kidney disease that will accelerate your vascular disease. Homocysteine is a substance that we all have in our bloodstream in a small amount. It comes from the breakdown of some of the protein builders called amino acids. Some of us lack the enzyme that breaks down in an effective way homocysteine, so the substance accumulates in the bloodstream. It can be measured with a simple blood test. It's not so frequent that we find people with very high homocysteine levels, but in those with vascular disease and or unexplained premature coronary disease, we always do the blood test for this. And if the level is high, the treatment is folic acid, which can be purchased over the counter at a dose of 1 milligram a day. At the end of this webinar, for those who came in late, we will send an email to all of you with copies of the slides so you can review them. The question is from Ms. Zimmerman. Her physician prescribed a cholesterol-lowering medication called Lofibra and Plavix, which is a medication that works on platelets, because she was recently diagnosed with vascular disease. In terms of the Lofibra, is a type of cholesterol medications that work quite well for triglycerides, not so well for cholesterol. If that's the problem, I think is the appropriate choice. If you have very high cholesterol levels and you can take statins are better. The statin family is a better choice. Commercially available, there are many of them. You see them in the television all the time: Lipitor, Zocor, Pravachol, Crestor, etc., etc. With regard to Plavix, it's a more powerful antiplatelet agent than aspirin. Works is slightly different, but the intent is the same. If you never try aspirin, and aspirin could be just as good in the setting of mild vascular disease. If you have a stents and other instrumentation of the vasculature, Plavix is the ideal choice. Any other questions in the audience? With no more questions, I thank you for joining the webinar. Few questions means that I was clear. I'm kidding you. There is one more question. I'm sorry. The question is about vitamin D and prevention of vascular disease. There is very little evidence that it prevents anything in terms of development of vascular disease. Vitamin D is good for other things, particularly when it's combined with calcium for bone-related processes, but for prevention of vascular disease, there is no data to support the use of vitamin D for this purpose. Thank you very much, and with this we close the webinar. We appreciate your attendance.